Okay. So today, of course, we have the Charlie Resnikoff. I think he loves when I say that, but it's a necessity. Well, we're jumping to objectives right away, but we'll go to the announcements. Of course, we're going to keep, chatting about Sam Quinones, and I could go on and on because I just love these books so much. The history of the opioid epidemic and heroin and Dreamland, and then The Least of Us is now fentanyl and that whole world. Meth is a big topic. And he lived it. He moved to these communities and had firsthand experiences. Brittany's laughing at me, I think. Anyway, he is going to be on Echo on November 2nd, which is, I can't even believe it. I got treated from Kurt like to this fake 5-course presentation when I won that bet. So don't miss, tell your friends. Upcoming Echoes, we have a lot. This guy who's coming on next week, Problem Gambling. He is a big national dude when it comes to gambling and gambling addiction. I found him on LinkedIn and he's got some cool videos and stuff. So I'm excited to actually chat with him. And then Renee, who we all know and love from back in the day, she was, head of the MAFP for a while now out in Boston. There's just a lot of cool topics coming up. Of course, turn on your videos for Charlie. Let us know if there's more than one person in your room. Chat it in. CME thing you'll get at the end of today, or an email. You'll see it at the end of the slide. So fill that out. Technical assistance. Of course, Kurt and I are always available. Most of you have our email addresses, so feel free that way. Our cell phone numbers. Erin is always available as well. If there's any kind of clinical workflow, nursing, any questions, or you can't get a hold of us, call her. And the online site, which has how you get on the Echoes, all of those things. The manual is done. It's currently in review from MDH. The access to the manual will be through this site. It will link you to the MDH site where it's going to be housed. If anyone wants copies of this, wants the actual hard version copy of it, let us know. It's crazy. It took us a long time. And this has changed. Don't go to Buzzsprout anymore. Just Google your favorite podcast site, The Addiction Connection, new topics. Today is the 4th installment of sugar addiction. We actually compare sugar addiction to the DSM-5 criteria, and it's the greatest thing ever. All right. So with that, I'm going to let Charlie take over.
So we're good. All right. So, and full disclosure, I could just go 3 slides and talk the whole time. So I'm going to try to be concise, and you can look at these slides later. There's more even that happened legislatively and is happening legislatively than we can even fit in the slides. So I might move a little fast, but I'm hoping we can have some discussion because some of these are sort of hot topics. That would be the actual name of the talk, hot topics. Okay, hot topics. Well, as you know, Minnesota has bipartisan control of government. The Senate is controlled by Republicans, and the DFL controls the House and the governor. And this year there are many retirements, including many sort of beloved senators, both Republican and Democrats, who have really made a difference for opioids and methamphetamines and all sorts of drug epidemics in our state. So things are going to change. Also, there's been kind of a cool team of legislators, and Heather knows these folks as well as I do. Many of you know these folks that have gotten things done. Dave Baker is rising in prominence. Liz Olson is rising in prominence, Republican and DFL right there. And they're both really rising in prominence. Don't be expected if either of them have leadership positions in the next legislative session. And they're both actively involved in the addiction legislation sort of caucus, if you will. The problem is, boy, things have gotten more and more contentious, not just in St. Paul, but everywhere. And I think I'm not going to get into the whole, Roe v. Wade being overturned thing, except to say, I think it really, for a lot of people, it's a deal breaker, both ways. And people that used to work together are having a hard time working together now because of this one issue. And that, regardless of how you feel about the issue, it's really sad to me that in general, our politics are getting less bipartisan. And then specifically right now, the issue about reproductive health, whatever, is so hot that so many people are angry about it that people who used to work together are not anymore. And that's worrisome because addiction had always been a bipartisan issue that could bring Republicans and DFL together in Minnesota. Not perfect, but they got things done. And so I would suggest to you all, I mean, I don't want to be, I have my own politics, but I really love talking to both Republicans and DFL and trying to get things done collectively. And I have had some of my best moments talking to people from the party that I don't ascribe to. So I just wish we can all stay bipartisan on this issue. That's my spiel. Here's what I'm going to talk about. There's a few updates before we get into this. THC edibles. How did that happen? Intractable pain, and there's a law protecting patients with intractable pain. There's Americans with Disabilities Act you probably heard about. We're going to talk about that. There's opioid settlement funds have come to our state, and what happens to the opioid settlement funds? A lot of local communities are going to get moolah, big money, because of the opioid settlement, or at least medium money because of the opioid settlement funds. There's a interagency sub-cabinet on substance use disorders, and then I have a grab bag of other stuff that we'll talk about. One thing to think about is that this Friday, I think this Friday is the deadline. Oh, no, November 1st is what is the deadline? I think November 1st is I thought I had it at, yeah, I think the deadline is October 5th, right there, October 5th. So if you care about medical cannabis being made available to people with opioid use disorder, should opioid use disorder be a qualifying condition for medical cannabis? If you have an opinion about that, the deadline to be heard is October 5th. And this is a MMA website. It's not through the MMA. This is just an informational website. You would email the Office of Medical Cannabis or mail the Office of Medical Cannabis by October 5th if you think it matters, one way or the other, that opioid use disorder would be a qualifying condition for medical cannabis. We can discuss that at the end. The other hot topic that hasn't been finalized is something called the MAT Act, the Mainstreaming Addiction Treatment Act. This has been passed by the House, bipartisan support. It's sitting in the Senate. Supposedly, our Senator Tina Smith, that's her name, right? Yeah, she is a co-author, but this is a bipartisan piece of legislation. And what the MAT Act would do, if the U.S. Senate passed it, is to basically X the X waiver, among other things. But we would be done with the X waiver. Nurse practitioners, PAs, MDs, everybody would be able to prescribe buprenorphine like we do every other drug. So if you really care about that, contact both of our state senators, or if you're out of the state, whatever state you're in. This does have bipartisan support, and it will likely get through the Senate. The Senate is busy with a lot of other things right now. I think the Democrats are prioritizing things that they may not be able to do if the Republicans take control. And this is something that, regardless of who's in control, might get through. So this has been bumped down the priority list, unfortunately. Yeah, so there's lots of elements, but the headline news with the MAT Act is X the X waiver. Done with the X waiver forever. So that's interesting. So that could happen any day. Literally, we could hear about that any day that Senate's in session, I suppose. So those are the sort of updates that are right now, but now I'm going to talk about last session. And the first one is about THC edibles because it's kind of the most exciting headline-grabbing thing. And I have a friend who's a marijuana enthusiast, and he said Minnesota just went from worst to first for marijuana lovers because previously no recreational marijuana. Of course, you couldn't buy cannabis except for the medical cannabis program, and the medical cannabis program is relatively restrictive in our state. But after this, basically, there's almost no regulation on cannabis edibles. I'll talk about what regulations there are, but Minnesota is likely to be like a hotbed for marijuana innovation now, whether we like it or not. And I'll talk a little bit about that. So basically, here's the rule of thumb in Minnesota. If it comes from hemp, it's legal, like hemp is. Anything you can extract from hemp, you can sell like it's any product, you know? Basically, it's just an agricultural product. Well, that made sense because hemp was very low content of THC, and THC is the intoxicant. But then technology happened, and now with new technology, you can take hemp, even though it's low THC, and you can still extract and purify that THC. And so you can get pure THC out of hemp, even though hemp is very dilute with THC. Plus, there's the whole Delta 8 and Delta 10 thing, which is a little like not the point anymore because you can have Delta 9. Delta 9 is the drug everyone wants. Delta 8 and Delta 10 were like sort of the, that was like the consolation prize. It was like kind of like legalized cannabis, but it wasn't quite. Anyways, Delta 8 and Delta 10, I think, are being extracted from hemp. Delta 9, which is the intoxicant everyone wants, now that's being extracted and purified from hemp, and therefore it's legal like it's a hemp product. Well, that's, the bill got through without, I think, either the Republicans are claiming they didn't understand it, or the Democrats confusingly communicated this issue, or it really was just confusing to understand. And so the bill got through, and a lot of people were surprised. And it was very kept hush-hush during the session. I had no idea. It was just kept totally under the wraps. I don't even know who knew it was happening. It did go through all the regulatory process, but it's a little confusing, and I think people just didn't know. So here are the regulations. Edibles only edibles. But you can get this edible at a coffee shop, at a co-op, anywhere. At a brewery. You can go to a brewery now and get a cannabis seltzer with THC in it. So 5 milligrams per serving, which is actually a pretty modest dose. That's an appropriate dose to start on. If I thought it was appropriate to start, I would say start at 5 milligrams or less. 50 milligrams per package. A heavy cannabis user can have 50 milligrams in a single dose, So a package is 50 milligrams derived from hemp, and you have to be 21 years or older. Okay. Like I said, 5 milligrams is a pretty conservative starting dose. So I think that's appropriately conservative given this. We talked a little bit about the political issues. I think the horse is out of the barn. I think it's going to be really hard to change this back to this never happened and now you can't get THC anymore. It's interesting to wonder, does this help the Democrats in the fall? And why did they do this? Why did the DFL sponsor and get this legislation through? I would expect in 2023 some more regulations, especially if the Republicans take control. I would expect more regulations, but I think they'll probably still be there, but there might be more. What I think we're hoping for is that the tax from these products gets funneled into substance use disorder treatment causes. I think that's the hope. But all that's 2023, depending on who's in charge and all the rest. I think you can expect this to change, but my guess is there'll still be edibles. And remember, any smoked cannabis, recreational cannabis, not hemp, cannabis is still illegal in our state. So, it's still illegal to have cannabis. It's still illegal to have derivatives of the cannabis plant for recreational purposes. That's all still illegal. These are hemp products. Okay, we're going to skip that. You guys, we'll chat at the end. The next big sort of headline news is the intractable pain bill. And I know Murray was, and I were both sort of asked about this. We both gave our opinions about this, and it's not totally clear what all, well, I won't editorialize, and I'll say, regardless of my expressions of feedback, this bill went forward and passed and was signed. Intractable pain. Clinicians never use that word. We say chronic pain, chronic pain syndrome maybe, or we list the cause of the pain. So to me, intractable pain is like a non-clinical entity, but it is a legal entity. Intractable pain is a legal term now. And what that means legally in the law is there's a group of people who can legally be given this diagnosis of intractable pain, and they are a protected group. So if one of your patients comes in and says, I have a diagnosis of intractable pain, that person legally has protections that everybody else doesn't have. So that's important to know. There's this protected group of people with quote unquote intractable pain. Let's see, a lot of this came in like pain doctors and patients were very unhappy with opioid regulations. And this is like, you might want to say backlash or writing the course or however you want to spin it. This is a reaction to opioid regulations. Okay. So they did read the definition of intractable pain is basically anything. They list sickle cell disease, cancer, and non-cancer pain. So they literally list cancer and non-cancer pain. That's everything, right? That includes every source of pain. And they list some other things as well. So literally anything can be intractable pain, but you need a pain specialist or a specialist trained in the disease. So a hematologist can designate intractable pain for sickle cell disease. But a pain doctor can designate intractable pain for anyone. And when I was talking about this earlier, Joe Bianco raised the point, hey, a lot of rural communities don't have ready access to all these specialists. So individuals in rural communities are going to have less access to this diagnosis of intractable pain. But right now, you need to see a specialist to get that diagnosis. But once it is called intractable pain, it's like takes on a life of its own. Because once you have intractable pain, you can't criticize someone for the causes of that pain or whatever. And then also, we're going to get to what the protections are. So first of all, nobody can deny a refill of an opioid solely based, and they use the word solely, that is in the legal language, solely based on the MME or dose of the opioids. Prescribers who are quote unquote appropriately prescribing for intractable pain are immune to state-based discipline, like Board of Nursing or disenrollment or whatever. So if you are prescribing for intractable pain, quote unquote, appropriately, that word appropriately is in the legal language, you're immune to discipline. And patients with intractable pain should not be tapered solely to meet MME targets. Okay. So, I mean, to me, my interpretation of this is, why would we solely taper someone for their MME anyways? We never should have done that. There should always be another reason to taper someone or why you're tapering them. And if you're prescribing appropriately, it shouldn't matter what the dose is. What matters is appropriate prescribing. And so I am reassured by the presence of those words, solely based on MME, and as long as they're appropriate prescribing, I feel like there's enough wiggle room in there to still sort of expect good behavior on the part of prescribers. However, I have colleagues that are not so positive about that and who really feel like this is going to send a chill through providers, and it's going to take a lawsuit to figure out what the significance of solely based on MME really means. So I'm optimistic that this is going to be less awful than some people think, but I have colleagues I respect that are very worried about this the implications of this intractable pain bill. If you have intractable pain, there are legal requirements to your patient-provider agreement. So maybe that's always been standard of care, but now it's standard of care and the law. And so if the patient-provider agreement is not met, you don't have intractable pain. So, that's a legal requirement for the diagnosis. So again, this defines a group of people who go to their subspecialist, get labeled with intractable pain and sign the patient-provider agreement, and they have legal protections against being tapered solely on the basis of their dose of opioids. And also the prescriber has legal protections. So, is that a good thing or not? Think about that, and we'll come back to the discussion later. That could be a hot topic for discussion. We have had patients in our pain clinic show up and declare themselves intractable pain. Like I have the cloak of invisibility, or I have the ring of power. I have intractable pain. So, it's happening. It's out there. Third update, the Department of Justice issued a memo on, is substance use disorder a protected disability? And the answer is yes, as long as they're not actively using drugs. So, and I'll elaborate on that. So opioid use disorder is a disability protected by the Americans with Disability Act, according to the Department of Justice. People with opioid use disorder have a disability because they have a drug addiction that substantially limits one or more of their major life activities. So if someone is discriminating against you because, one, you have opioid use disorder, two, you hang out with people with opioid use disorder, or three, you are regarded to have opioid use disorder, and actually four, you are being given a medication for opioid use disorder, you cannot be discriminated against for any of those reasons based on the Americans with Disabilities Act. So, however, if you are actively using drugs, that does not apply. Tons of examples, okay? I'm gonna give you some examples. A skilled nursing facility, these are directly from the Department of Justice. These aren't my examples. This is a DOJ. A skilled nursing facility refuses to admit a patient with opioid use disorder because the patient takes MOUD. And anyone who works with methadone patients sees this happen all the time. Nursing homes do not want to touch methadone patients. The facility prohibits any of its patients from taking MOUD. This is a violation of the Americans with Disabilities Act. So you can't be a nursing home and say, we don't accept patients on MOUD. Or, I'm sure Heather will have a perspective on this because she's done incredible work in jail medicine. A jail does not allow incoming inmates to continue taking their MOUD prescribed before detention. The jail's blanket policy prohibiting the use of MOUD would violate the Americans with Disabilities Act. That's going to have huge implications for jails nationwide. I don't know if that's actually gone into effect, but a lot of jails in our state and our country aren't hot on MOUD. Our state's better than a lot of other states, but yeah. Doctor's office has a blanket policy denying care to patients receiving treatment for OUD. Think about a pain clinic's office or a surgeon. We just don't, we don't have good results with patients with MOUD. We need you to take. I know psychiatrists that tell patients to taper off their MOUD, and partly in order to get their benzos or whatever. It's crazy. That's clearly a violation of the Americans with Disabilities Act. Okay, we got a couple more. We don't have to get dragged into the mire on all these examples, but mentoring program requires its volunteers to provide a drug test showing that they did not engage in illegal use of drugs. The program dismisses the volunteer because the volunteer tests positive for opioids, to which the volunteer does not have a valid prescription. This does not violate ADA because it was an illegal use of the opioid. So you can be fired for illegally using an opioid. You cannot be fired for legally being on MOUD. The hospital emergency rooms turns people away who are experiencing drug overdoses. I don't know where that's happening. It must be happening somewhere because the DOJ had to comment on it. Anyways, clearly hospital emergency rooms turning people away from an overdose is a violation of the ADA. Drug rehab programs asks a participant to leave because the participant routinely breaks a rule prohibiting use of illegal drugs in the program. This is not discrimination. So if you use drugs while in inpatient treatment, they can kick you out according to the Department of Justice. On and on and on. So there's lots of other examples. Basically, if it's discrimination of a person because of MOUD, but not illegal drug use, it's against the Americans with Disabilities Act. If it's based on illegal drug use, it is, you can fire the person or not see the person or kick the person out of your nursing home or whatever it is. So bottom lines, patients with opioid use disorder are protected from discrimination based on their diagnosis if they are not actively using drugs illegally. But define that. What does current drug use mean? And we were talking about this the other day. So, I mean, we just had a patient go to Hennepin County Jail. She was using drugs up until the point in which she saw someone overdose. The first responders arrived. I don't know what they saw on the scene, but they arrested her. That's a whole other story. But then she came to the hospital before she went to jail, and she was started on MOUD, and she said, I really want to be sober now. And then she went to jail. Well, it was only 24 hours between her using illegal drugs and her in jail. But is she currently using? She used 24 hours ago, but now she's saying, I want to be sober. But she only said that because she knows she's going to jail and she wants MOUD. So it's complicated. I think if someone is actively using illegal drugs while they're employed, I would consider that current. Even if it was a week ago, that seems like it's still currently using. But if someone quit using drugs and then got employed, and it was still a week ago, but they weren't employed at the time, I might say that's, anyways, the courts will figure it out. So this is going to affect our patients. The nursing home placement thing is huge for me. It's going to be huge. But it's probably going to take a legal case to really motivate nursing homes to change their behavior on this. Okay, I'm going to keep going forward, see if I can get through all this stuff, and then we can discuss. There was a lot of like $340 million worth of a settlement between the Attorney General's office of the state of Minnesota, Keith Ellison. He got a settlement with the opioid big pharma, and got $340 million, which will be spread out over 18 years. And so they needed a legal way to disperse these funds. 25% of the money is going to go to the current opioid epidemic response committee activities awarding grants. So the ORAC activities, 25% of the money goes to that, and 75% of the money goes directly to the counties. So a lot of counties are going to get money, and there's a whole process for how the counties are going to get this money. So that's pretty cool. Downside, this settlement releases the defendants, pharma, from current and future opioid litigation with the municipalities within the state. Opioid Epidemic Response Advisory Council is going to, the ORAC is going to consult with the local municipalities about how they use their meds. And there's got to be reports and everything else. But I think the issue that some people take exception to is that Big Pharma they paid $340 million, but they are released from litigation on opioids in the future with our state. So that is $340 million enough to release them. A couple more. The governor announced a interagency subcabinet on the substance use epidemic. Basically, all these different areas of government affect opioid epidemic, methamphetamine epidemic, and they're not talking to each other well. So this sub-cabinet is a way to get all the different branches of government to play together nicely. And that will include Department of Human Services, Minnesota Department of Health, Education, Higher Ed, Public Safety, Corrections, Budget, Council on Homelessness. And we're going to, now we, Governor Walz, I'm not part of we with him, Governor Walz is going to stick them all together on a committee and make them talk it out and coordinate better. So that's the idea. And then part of that is that this sub-cabinet will need an advisory council. And applications are in for the advisory council. I think Tim Walz is probably going to wait until November to if he gets reelected, I think we'll hear about this. I think, but I don't know. There hasn't been much movement on this since they announced it, and I think they're just waiting for November. But we'll see. So that's in the works. And then quick updates, and then let's discuss and debate. Rule 25. I don't know about you, but I am pretty happy that the dang Rule 25 is no longer a barrier. Patients can just call the treatment center and say, hey, I have opioid use disorder and I really want to get treatment there. And then the treatment center can directly help them navigate the process, and the treatment center can then directly apply for funding from the state. I'm sure this is not a perfect process. Occasionally, patients waste time by going to the wrong treatment. But at least I think it's been I was over Rule 25. Wake up at 6 a.m. and wait in line in January in Minnesota outside some downtown building. Yeah, right. So Rule 25, sayonara. There was some hope that syringe programs would get a more clear and explicit protection from the law. That didn't happen. But hopefully in 2023, syringe programs are happening. They occur, but there was some hope that there would be more explicit protection, because technically syringes are still drug paraphernalia. Technically, depending on how you interpret the law, some of the syringe programs could be legally in a gray zone. I think everybody wants to protect syringe programs. It just didn't happen, and nothing happened. A lot of legislation didn't happen last year. Sober home regulations, the Americans with Disabilities Act applies to this. So the sober home, there was a huge series of re-regulating and sober home, because sober homes are like, they're very helpful when they're good, but they can be kind of the Wild West. There's a whole spectrum of regulations and quality, and what is this? Is this just renting an apartment from someone and they say it's sober versus it's truly a sober space? And how do they manage behavior, and how do they manage meds, and how do they exclude and kick out patients and all the rest? So there's improved regulations on sober homes that should be happening. Plus, Americans with Disabilities Act protects people who go to sober homes. And if anyone here is or is considering becoming an LADC, they've expanded tuition loan forgiveness to include LADCs, which, that's great. Now we should pay LADCs more, but I think that's great. And hopefully it attracts more people. And let's chat. That's all I got to say. I went kind of fast, but hopefully that was okay.
Okay, I will promise all y'all, I will start with your questions before my page of questions. And I'm going to avoid all the jail ones till the end, because that's where mine go. Yeah, and this was great. So let's go back to the hemp thing really quickly, or I'm going to lie. Sorry, I'm just like all over the place. As far as the ADA and the treatment facilities, Charlie, like we've had, there's treatment facilities in Minnesota who don't do MOUD. And so how does this apply to actual treatment facilities with that? Are they going to be required now to also offer that?
Yeah, that's a good question. In theory, none of the DOJ put this out, and then everybody's holding their breath. And I don't know that many nursing homes or treatment facilities or jails that have actually changed their behavior. So I think everyone's kind of holding their breath, waiting for some legal cases to sort of give some clarity, hoping they're not the one who gets sued. The DOJ does not specify as one of their examples what you asked. So I'm kind of guessing. I think here's my guess. If the treatment facility says, we are fine with MOUD as a treatment, but we can't have people requiring transportation to their clinic because of logistical reasons, not because you're on MOUD. So the law is you have to be discriminated against because you're on MOUD. But if the treatment facility kind of makes that a sneaky workaround, like, oh no, we're fine with MOUD, we just can't get them to their clinic and back, or something like that. I think treatment facilities are going to be able to wiggle out of it. I don't see every treatment facility accommodating patients with MOUD. I don't see that happening. For that to happen, it would probably need to go through our state, and our state would say, if you want to be eligible to receive Medicaid funds, you need to do it. But I was in a committee with, I think, March. I talked to March, the organization March, and they were sort of uncertain about whether that would be the right move on the part of the state. So I think a lot of people still want to create space, like treatment recovery spaces where nobody's on MOUD. I don't see it, like I don't appreciate that, but a lot of people still want that. And I think there are ways to wiggle out of the letter of the law of the DOJ. You just need to find another reason why MOUD can't be there, and say, we're fine with MOUD, but here are our pragmatic issues, and then you can exclude them. That was a long answer, but the short answer is, I don't see treatment facilities fully. I think it might improve it a little bit, but until there's a legal case, I don't think it's going to change. That's my opinion.
Yeah, because I mean, the problem, even like they don't even have to be able to prescribe it, let alone go to their appointments. I think that's also a big deal, saying we don't do it here, so sorry. Now, there was a comment about treatment facilities not accepting a patient on a direct referral or on self-admit or whatever, because they don't have the Rule 25/chemical use assessment. Is that, do you think, just kind of this transition period, or like, how do you work with that? Interesting.
Yeah, that's a good, I mean, I had not heard that. And that is, thanks for saying that. I learned from that. And I guess now that I think about it, taking away the Rule 25 does allow this sort of like, puts more power in the hands of the treatment center, and they may then use that power to sort of pick and choose and come up with reasons not to take patients, if that's what the questions. I hadn't heard of that, but I guess that's a really important concern. I would need to talk to the LADCs I work with who are placing patients to see how common that is. That's worrisome. Yeah.
And I think some things I've heard with this question is that you need that assessment prior because of the whole insurance thing and all of that. Whereas my understanding before this happened was that that was supposed to be done at the facility. And so I'm hoping it's just this gray transition zone where, you know, LADCs and whomever are doing the assessments, which I think all have to be LADCs now, to do the official chemical use assessments. It's just that learning curve. Question about this is interesting as well, about if these regulations and everything you just talked about apply to tribal nations.
Yeah, good question. I mean, I know specifically some of the state waiving the right to prosecute pharma. I don't think that applies to tribal nations. I asked about that a couple months ago, and I think tribes still have the right to prosecute pharma. The rest of it, I don't know. I'm not sure. Yeah, I'm not totally sure. There's an interesting law enforcement thing where you all may know this better than me, where some law enforcement from Minnesota happens on the tribes, I think, on the reservations, but sometimes I don't know where the line gets drawn. So I honestly don't know. Thanks for asking.
Hey,
Okay.
Charlie or Heather, if part of the question was about, the tribal nations had a separate settlement, and the settlement that Charlie was going over at the end is with the Minnesota State Attorney's Office, and then with the local governments, tribal nations had a separate lawsuit settlement and separate, I think money coming to the tribes here in Minnesota. So if part of that was that, that's kind of how that played out.
Yeah, I think that's going to be interesting, Dana. And I know we've talked about this a lot on ORAC, and if we're thinking jails with that and how that looks, and then that's going to be fun.
Yeah. And Kathy Nevin put something into the chat. The tribes have a separate settlement.
Yes. Okay, as far as telehealth reimbursement, are there any changes there? And what do you see going for that and into the future?
Yeah, I mean, that's something I should have looked up. I mean, there's two issues there. I think there's one is telehealth, billing for telehealth, telephone and telemedicine, and two is controlled substances. The DEA changed some of their requirements for prescribing controlled substances. Those haven't been changed back. I don't think they're going to go all the way back, but they might. But the DEA did loosen some. So it's both telemedicine reimbursement, telephone and video separately, but it's also, can you prescribe controlled substances over the telephone or over a video visit? And I think both of those, I don't know the status of them both. I have not heard. And that will be interesting. I think it's going to stay mostly the same, is my opinion. But if anybody else has more knowledge on this, please share.
Okay, so you talked about this hemp thing. Have you seen, because you said it only applies to these non-smokable, non-recreational usage. So if you have these edibles over the counter or whatever, have you seen or heard of people using the edibles in different ways? As far as, are they able to, I don't know. I'm just curious if you've heard of that. So it ends up being more of the recreational use versus the edibles.
I mean, a lot of people are using edibles, like eating them and getting intoxicated from it. And then I think the innovation, there's going to be a lot of innovations. I think there's enough cannabis in our community now that if someone wants to smoke or vape, they'll just go get black market cannabis. But there are a lot of innovations with this THC stuff. And I think the beverages, THC containing beverages that are sold in breweries, and drunken driving, if you mix THC with alcohol, is way worse than either alone. And so you got breweries selling alcohol side by side with THC containing seltzers. I think that's kind of an innovation. There are teas. So there are teas and other beverages, but those are the main innovations that I'm hearing. Are people using them in other kind of creative ways? I'm sure, but honestly, there's so much cannabis out there. I haven't heard about it. I'm not like I'm not like the expert on it.
Yeah, and I don't know how you'd ever even prove it. Like this was hemp or this was an edible versus, like you said, just going and buying the cartridge on the black market. There'd be, are they going to look at levels? Well, that can be a lot of different things. So
yeah, and I think that's a good point. Like now, any doctor who gets a drug screen that shows THC, the patient has like a very built-in, it's legal response. And maybe they did consume legal hemp-derived THC, and maybe they were smoking a blunt. Nobody will know because all you can detect in the urine, or in urine drug screen right now, typically you just detect the THC, which could have come from various sources.
Well, that'd be interesting.
Sorry. I just was going to ask, and I'm sorry I joined the party late here today, but if someone is using hemp-derived product, they wouldn't test positive. They shouldn't test positive for THC, should they?
No. Now the issue with the new thing in the state is that if people are extracting THC from hemp, and then purifying it and using it in food products in our state legally. That's legal. That's the law that passed through and kind of snuck under the radar of the legislators. So it's hemp-derived THC. So, and that's kind of mind-boggling because THC by definition is not, I mean, hemp by definition is not supposed to have THC,
Right.
but it has enough different THC to be extracted and concentrated.
Oh, interesting. Okay, thank you for that.
Yeah.
I didn't realize that.
And honestly, I wonder if you really looked at where all those THC edibles came from, did they all actually come from hemp? Like, I don't believe it. Like, I think a lot of this actually comes from cannabis, but we'll never prove it unless there's some, like, major investigation. I just wonder how many of these legal hemp edibles are actually cannabis edibles. But like
Yeah, I think you're really right. I have a colleague who does CBD for a living, and she actually has her CBD go through a lab to show the hemp derivation or whatever. And but she said if they're not doing that, they're just deriving it from THC. So
yeah, and like importing it from Oregon or Washington or wherever, and then rebranding it and calling it hemp-based CBD or whatever.
So that'll be interesting then with child protection. Just thinking forward is that, child protection won't be able to do that now or how they're going to approach it. It's just my new thought in my mind. I've had a patient yesterday. So, okay, let's go to corrections, Charlie. So I have, speaking of child protection, I have, obviously the Minnesota laws with mandated reporting with that changed as far as pregnancy and using substances. Prior to the change, it said you're mandated to report if they're actively using substances. Well, there's a gray zone in there, and I wonder how this is even going to be interpreted in all of these laws. Is someone gets arrested, brought to jail, they might have stuff in their urine that isn't just their MOUD, meth, whatever. They're not actively using if they're sitting in the jail, usually. And so that's going to be an interesting fine line, is how do you define actively using? Yeah.
Yeah, I mean, yes. And I think people will use that however it suits them until somebody sues somebody and a court tells us how it really is defined. Right. But I think there's a lot of people that are going to use it how it suits them.
Yeah, funny, Dana. There was one jail facility we were talking with, and they had their lawyers look at this ADA, blah, 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 DOJ, this whole thing that just you talked about. And their lawyers were like, well, this would be super easy to fight, don't even worry about it. You don't have to do this. And that's obviously very sad. But with that, there was a good question in here about what about the methadone? And I know obviously having been in jails, if you're in a jail in the middle of nowhere where there's literally no methadone clinic, but the person who maybe goes to Hennepin's methadone clinic happens to be driving through, Fergus Falls, like how do they even comment, or do you even have any idea how these jails are supposed to get that methadone? Because I know right now chain of custody is a nightmare.
No, and this gets to what we were talking about earlier, where the jail could say, we will let them have their methadone, but how the heck are we going to get it? And until we can get it, we're not going to do it. And it's not because we're against methadone. It's because we're 3 hours away from the nearest methadone clinic, so there's no freaking way. And I think that would be very hard for DOJ to win a case if that was what the jail said. And, I think the jail says, we're not against methadone. We're against driving 3 hours to go pick up the methadone. So make our lives easier. Like, that's important. We can't do that. It would break our bank. So I think that'll be that. I think that's an example of where jails are just going to be like, no way. And I think they're going to be able to do that.
And realistically, they don't have the resource right now. They don't have, that's a legitimate say, they don't have the resources. They're so short staffed right now that
Totally.
Yeah.
And I think the spirit of what DOJ is saying is, as long as it doesn't come from bias against methadone, it's fine. If it comes from, we're broke and we can't go drive 2 hours to get methadone for every patient because we just can't run the jail that way, that's not a bias against methadone. That's just we're trying to keep the jail operating. And then it wouldn't be discrimination, right? That's just them trying to operate their business or their jail, whatever.
Yeah, there's an interesting thing that we've run into with doing the MOUD in the jails is a patient leaves, they get sent from A jail to B jail because they, they're on a hold. And so they get sent from a jail that appreciates MOUD, maybe starts MOUD, but then they're going to a different county jail that's like, we don't do MOUD here. So does the first jail just never start it, or do they have to taper it? And what happens at the new jail?
Yeah. We won't start methadone in a patient. This patient going to Hennepin County Jail yesterday, our methadone clinic supervisor was like, be sure they're not about to get transferred to another county, because if they are, we're not starting them, because it just doesn't make sense to start them and then in 3 days they're off it. That's just wasting everybody's energy, and it doesn't help the patient. So yeah, I think that's an issue. People get transferred jail to jail all the time. I got to go because I got an appointment. Ashley has this awesome question, and I think Heather could be a good person to answer it. I do want to say, Kathy, the Minnesota Medical Cannabis Program has just allowed smokable. They're selling bags of marijuana buds. They're selling joints. The prices should come down. I think medical cannabis might go. I think as long as there are children who need CBD, there will be medical cannabis in our state. So I don't think it's going away. It'll change if there's legalization. I do think that. But I don't think it's going to go away for any time soon, because there's like 5-year-olds with seizure disorders who need CBD. So there's always going to be something. Okay, super fun. I'm sorry to have to go. Thanks, everyone. Hi, Kurt. Turn off and go be on vacation, Kurt.
Right?
Well, I'm just trying to become a country star down in Nashville. That's what's going on.
Nice.
Yeah, not possible. Then you could stay there. Just kidding. Okay, so this behavioral health fund, that's a great question. I don't have the answer to, and I don't know, Dana, if you're still on and you have comments about that, like from the state side, or Ryan, Kelly, I think you're on. I'm gonna maybe wonder if you have a better answer to that question about tapping into the behavioral health funds for buprenorphine coverage versus OTPs. I'm sorry, Ryan, sick everybody, so ignore his voice.
Everybody. Actually, I don't know. Sorry.
So Ryan, since you're on, do you want to also maybe give, and I don't know if this is what you want to talk about or if it's even appropriate for right now, talk about some of the decriminalization things that might be coming. Charlie didn't talk about it, which is why I text you to join, because these are steps that at least a lot of us in the state are really hoping, and or at least the comment about the urine drug screens, because I think that discussion is very interesting, like last night.
Well, nice. Well, yeah, sure. Again, pardon my voice. So, very briefly, so the Minnesota Medical Association's Health Policy Committee voted this year that the number one priority for the committee is looking at drug decriminalization and harm reduction policies. And so there's a subcommittee that Heather's a part of, as is Kurt, that is creating language on policies addressing those issues. And so this document's almost complete, and then it's going to go to the main committee itself. If they approve it, then it goes to kind of the Minnesota Medical Association higher ups, and then it would just be a part of the MMA's policy. But then it would be something that policymakers, lobbyists, et cetera, would be able to look at as they look at policies that would impact Minnesotans. But some of the things that we're looking at are, when it comes to harm reduction, certain exchanges, making them more a part of something that's more supported, decreasing stigma when it comes to employee drug testing, overdose prevention sites. And when it comes to drug decriminalization, really emphasizing that, instead of putting people in jail, if we instead offer social supports, et cetera, we save money and lives. Is that a good summary?
That's a great summary. And I don't know if you were on yet, but there was definitely a comment by Gert about someone who in this chat talked about using the funding from the medical cannabis or all of that to go towards some of this decriminalization and go towards treatment efforts. If anybody is interested, look at the Portugal model and ignore Oregon right now. Oregon's the only state that's done this decriminalization, and I have opinions that Ryan knows, but the thing isn't necessarily legalization of all drugs. It's helping patients get into treatment rather than sending them to jail where who knows what will happen. It's not, obviously, if it's a violent crime, that's a different story than simple possession charges and things like that. So yeah, stay tuned for that. Does anybody else? That's a good comment, Carrie. Ryan, we should write Carrie's name down, our interprofessional group to work on some of these things together. I mean, not some of these things, but to work on pushing that at the state level. Any other questions, comments on any of this? Ryan, thank you for at least speaking to some of that. We did get through the decriminalization verbiage last night. That was voted on and unanimously after debate. So that one did get done, but the other one did not. Any other following questions, comments that anybody has? Carly covered a lot of things.
Hey, Heather.
Yeah.
This is Chris Matson. I just want to run something by you and the others. So my background is as a pediatrician. I was very involved with special ed law, both the Department of Education law and the Office of Civil Rights law, the 504 and the special ed law. So when you're coming at this from a person with disabilities, I can see where, let's say, one of my patients on Suboxone goes to jail, and it does happen all the time. And they say, and we recently, like a couple of weeks ago, started the local jail in Bayfield, Wisconsin, to let people start taking their Suboxone. Brand new. I've only had one patient that was given it so far with this particular administrator. Okay, so I have a patient, they go to jail, they're on Suboxone, and they get their Suboxone. Great. Now, another patient comes in, and they have the same exact problem of opiate use disorder that my patient does, but they have never been treated. Their doctor was against Suboxone, or for whatever reason, they never had an evaluation and they didn't get treated. That inmate is going to say, I want Suboxone. I want to be evaluated. I want to get on Suboxone too. How dare you discriminate against me because I'm not on Suboxone already? Because I didn't, my tribe didn't offer that at my local clinic. I had no way to get on it. So how dare you, and I would be very sympathetic with this argument, how dare you not evaluate me for my disability and treat me for my disability? And doctors like me, I would do it tomorrow. I would go to the jail and I would do an evaluation for opiate use disorder, and I'd start that inmate on Suboxone. I've offered already to the jail to do that, but it's this thing about already being on Suboxone is a problem. I think I don't think it's going to stand up for a test of patient civil rights.
So this is a topic like in Little Falls we were dealing with back as far as 2016. Chris, you're speaking to the choir here. Actually, the nurse that we got to help push this in Morrison County back then, and I work with now. But having worked in corrections, this is the biggest sticking point I had. And there are so many factors that get to play into that. We have a whole talk on this that we bring to jails. County commissioners get to have a say, the sheriff gets to have a say, the jail administrators get to have a say, whoever does your jail medical gets to have a say. Jail medical is a contracted thing in most states. I think Wisconsin, well, I know Wisconsin's a contracted It might be contracted with your local public health or a company that does only jail medical. And a lot of it depends on the policy and the discussion between both, because if your staffing issues already in your jail and now you want to throw in Suboxone, there's a lot of things you wouldn't think of that have to go into that, as far as timing of dosing, how you dose that medication in the jail, who doses that medication in the jail. Are you putting a target on the patient who has it, target on their back because of the other inmates that want it? I 100% agree with you. We actually have a program in Minnesota, a grant that we're doing with Stratus Health on this exact topic, is getting MOUD starting in jail. Another big barrier is transitioning to a community clinic. And I hear you, if it's your local jail and you're right down the road, but if you have an inmate that lives in a totally different county or in a totally different area of Wisconsin or wherever, and the closest MAT clinic or MOUD clinic is 2 hours away, then what? You have to coordinate that person's release with their medication. There's a lot of things, and I don't agree with a lot of them. I think this ADA thing with the DOJ is the first step, is continuing. That being said, is every jail and everybody who has a say in that jail has a different interpretation. You know, some places say, well, we'll continue it only if they were on it for 6 months prior, or which that's a gray zone. And again, could a jail or lawyers argue that? They probably could, because they can argue short staffing. They can argue how often they actually have nursing in their jail. What I would say, Chris, for you in Wisconsin is you have a bigger uphill battle than we do in Minnesota, just based on the political atmosphere in Wisconsin versus Minnesota. But I think it's going to be coming. There's a lot of people nationwide that we have talked to on this topic that actually are super motivated in this, sheriffs and whomever, that is going to push exactly what you said. And it will just take one patient, one lawsuit with the right lawyer, and to win that case, exactly what you said, that discrimination versus another patient. There was a question in there about what about other substances, you know, like discriminating a person with meth. So that's always my thing. Okay, they're on their MOUD, they come into jail, they don't have opioids in their system, they don't have fentanyl in their system, but they have meth in their system. Okay, now the jail stops their Suboxone because they have meth in their system, or marijuana, which is hilarious to me. And so it's very hard, you know. Patients aren't always forthcoming because of the questions at booking get asked in a stigmatizing way. Yes. Yeah, and a lot of the healthcare in Wisconsin, the company that does a lot of Wisconsin's jails is very not buprenorphine friendly. And that's the healthcare. And so I wish it was so easy. I used to think it was that easy when I lived in Little Falls and just practiced in the community before I ever met the jails. It was so frustrating because I'm like, why can't I just do this? Why can't I, you know, we did a workaround in Little Falls where if I knew my patient was going to jail on a previous charge, I would write the entire script to cover their whole jail time and send it with, and we convinced our jail to just continue it. Our county is a small county and they could do it. We can talk, I can talk about this for hours. I wish there was a good answer. Kay's shaking, nodding her head because we've been dealing with that jail, and it's amazing. Certain jails you wouldn't expect are on board and some hate it, and we're working on it. I can promise you we're working on it. Okay, I think we are over time. We do have a case that we will do next week in all hopefulness. Otherwise, I will address it offline and then we will bring it back at some point too, just to all have that case